It's Dr. Abuhantash from Jordan, but it's okay.
Okay.
Chairman and Chairwoman actually sitting with you, thank you for the invitation. I don't have a fancy case like the other ones which you had today, but it's a bit of an educational case. It's not late presentation, actually it's somebody who came after hours. So it was an early presentation, but after hours. My patient is a 61-year-old. He's a pharmacist, ex-smoker, hyperlipidemic, with type 2 diabetes. He came to the emergency room with ongoing chest pains of 2-hour duration. This is his ECG. Obviously, ST elevation in the septal leads and reciprocal ST depressions. I gave him ticagrelor 190 milligrams and fractionated heparin 5,000, atorva 80, metoprolol 100, all of this in the emergency room. And he was shipped to the cath lab. I do right radial, my usual approach, even STEMIs. Got a 5 French RCA diagnostic catheter, knowing that the culprit is in the left, and the right does not have any major issues, as you can tell. Went to the left, and you can immediately see a 111 bifurcation lesion. The ostial LAD is severe, and if you have a very, very good eyes, you will appreciate that there's a filling defect sitting in the ostium of the LAD. I took a guide, of course, immediately. It was not a diagnostic catheter. So what I'm dealing with is a patient who's still early on with his ST elevation anterior, with an ostial clot in the left anterior descending artery, and a 111 lesion in the left main. So the patient is stable. His ejection fraction, I did an echo quickly, actually, before I took him to the cath lab. It was good, 55%, with some antioapical hypokinesis. I called my surgeon, who was wonderful enough to come and share with me what to do. He was actually offering to do the bypass, but he expressed to me that he's a bit worried that in their surgical literature, beyond 2 hours, patients do not do very well in terms of getting LV function revived, and at the same time because of the complication rate. To me, it's like the usual surgeon in a STEMI patient. A lot of times they don't like really to take them to the cath lab. So he and I, as a heart team, agreed to proceed with intervention. I gave him IV tirofiban bolus and infused it, got 2 BMW wires, one in the circ and one in the LAD. And at that time, I was thinking whether I should do provisional. At that time, actually, the DKA crush was not still out from the TCT last year. So I wanted to do a provisional if I can. So I put a balloon, which is 3.5, 15, ballooned the LAD while the wire is protecting the circ. And you can see that the angioplasty did some better type of imaging, and that you cannot appreciate the filling defect anymore. This is after that, I put a 4018 DES. I didn't use a self-opposing stent, obviously. And I inflated that to 12 atmospheres and actually covered the ostium without major protrusion in the ascending aorta. This is my pot, again, and I saw everybody insisting on doing the pot, which I do all the time. And one thing about the pot, you notice that I pulled the circ wire out. A lot of people would agree with that. That's open for discussion, I guess. But I did the pot with 4.512 NC balloon up to 14 atmospheres. And after the pot, the patient who was stable became unstable. He had severe chest pain, and he had ST elevation on the monitor, which I didn't know which lead it's coming from. But I could tell immediately that there was a distal embolization, and if you look carefully, you can see a stain in one of the obtuse marginal branches. It's over here. Tirofiban is going, and the ACT was above 300, if you're wondering. So I immediately re-accessed the circ with another wire and opened the strut covering the stent of the LAD left main with a 2.515 balloon. The patient was feeling better already, and I put a 4015 DES in the circ with some protrusion in the left main. took my time to make sure I don't protrude a lot, but I wanted to protrude, but I didn't want to protrude a lot. The stent was deployed, it's 3.515. I'm sorry, it was a 4.0 stent in the circ. And there was a 3.515 balloon in the LAD actually sitting there. So what I did, inflated the stent in the circ with its protrusion, then inflated the balloon in the LAD, more or less like a reverse crush, and did final kissing balloon for both lesions, which everybody I'm sure would agree with. And my surgeon is a wonderful man, actually. At that time, he was telling me, yeah, patient is doing well, but look at this LAD lesion sitting next to the diagonal. I don't think it's a good idea to leave it. This is my diagnostic. If you look on the left side, there was a little lesion there, but I'm not sure how bad it was. I'm sorry, it's not working anymore. So I followed his advice, and I put another stent. It's a 3.515, deployed it to 14 atmospheres. Don't hold your breath. Nothing happened. Everything went fine. But it was upon his recommendation. There was a little bit of a black shift in the diagonal, but I got a TIMI-3 flow in the LAD, in the circ. The left main looks beautiful, and the surgeon was happy. And I was happy, of course. Now, why am I showing this case? I think, though it's not as fancy, as I said, as the other cases, it's not that complicated, but I think this is the ABC of doing left main in the after hours, and you have a STEMI patient. You have to follow steps, step 1, step 2, step 3. Don't rush your decisions just because it's after hours and it's a STEMI patient. Please look up this from the circulation in June 12, 2017. The recommendations for left main disease. Heart team approach is advised. What favors PCI, look at on top of the thing, the clinical factor, urgent revascularization. And I think in the after hours, in the middle of the night, whenever, when you are having an emergency situation for the left main, I think interventionists a lot of times will do the job rather than the surgeons. So what did I learn? That complex left main 1 Medina lesions presenting with STEMI are best approach as a heart team management. And this was done prior to the TCT 2017, as I said, where DK crushed data came out. And I'm not sure if I would have changed my mind during that acute procedure to do a DK crush or not. That's open for discussion, I guess. Thank you very much. This is Petra in Jordan. Night vigil, beautiful, and come and visit sometime. Thank you very much.
Thank you for the excellent case. So now, how did you treat the distal embolization? How did you treat the distal embolization?
Why?
How did you treat it?
How did I treat it? Well, all what I did is I checked the ACT. The ACT was above 300. Tirofiban was going. You know, I gave him ticagrelol, the patient. As a matter of fact, I don't know, you experienced, chairman and chairwoman and the audience, it happened after the pot, actually, immediately after the pot when it happened. And my own explanation for that, probably there was a residual clot sitting there. And when I put it that, it just distally embolized. So all what I did is just re-access the circ, open the strut, and with opening the flow, immediately the patient regained his stable condition and everything went fine. Without doing any special thing to the OM, I didn't even touch it.
No, I think it's important to treat these distal embolization with pharmacological therapy, if possible with the drugs, intracoronary drugs, and even sometimes selectively with the microcatheter. So make sure you get a good TIMI-3 flow before you do further intervention, because you have done a circumflex stenting, you've done a kissing balloon. All these can further aggravate distal embolization and further compromise the flow. So I think fortunately for you, I think there was not much of a problem. I think that's why you went ahead and the final result was good.
Would anybody have...
Yeah, please go ahead.
It was a very nice case. What I would have done differently is to use pharmacology. You're not in a rush to clear up the thrombus and wait for a few days and then do the intervention. There's no need to rush. You give pharmacology, you clear up the thrombus, and you're in a much more stable situation to treat the lesions you have to treat.
The patient's had some ST elevation.
He was
The patient has had ST elevation, though. He's been unstable in the last 2 hours. Often they come, they're pain-free, and they'll cause mayhem
Okay.
an hour later.
The other option is to give intracoronary thrombolysis and then wait a few hours.
No,
Can I answer this, Mr.
yeah,
Chairman?
please go ahead. Answer.
I think this is a beautiful way you're thinking about it, but I'm not quite sure it's supported by the data which we have. The first STEMI showed beyond doubt not to do it. I mean, when you have a STEMI patient, a clot sitting there, it's our job to solve it. It's not our job to defer it. But I respect that. I mean, I don't know what everybody thinks about it. So.
I have to disagree. There's an Italian group of investigators who used intracoronary thrombolysis 2 years ago to treat vessels with a lot of thrombus burden, to restore the reperfusion and then do the treatment. So I do disagree with you.
Okay, let's have the view of the panelists. So what I would do is, when there is I feel there is a significant lesion in the LAD as well, so I would definitely consider doing a PCI in the same sitting. In a scenario where there's only thrombus, probably I would have done exactly what you told. There was only thrombus, maybe treat pharmacologically and maybe take him up for a check angiogram later on or do imaging to see what's happening and then decide. And intracoronary thrombolysis, unfortunately, there is not much strong data for using intracoronary thrombolysis.
There is one trial. There is only one trial, I think, published in New England 2007 from a Turkish group, but this data I don't think that ever been replicated in other settings. Another possibility perhaps was to use intracoronary GPI. I mean, it's the largest antithrombotic drug that you can give in this case, like intracoronary abciximab, only the bolus perhaps, but I would absolutely go for fibrinolysis or lytic agents.
So how would you treat it? You would stage it or you would do it at the same
No, I
sitting?
would have done it exactly how he did.
Would anybody have thought about doing aspiration thrombectomy for the patient?
No.
This age, nobody
I
does.
think
I guess.
after wiring is useless. Stent implantation, I mean.
I think with no data on aspiration, I don't think, and again, the magnitude of thrombus is not so, the thrombus burden doesn't appear to be so huge.
Yeah, I completely agree with you, but I want to ask you one question. What size of guiding catheter finally you choose?
I went radial. It was a 6 French ABU. I think it was a 0.071 diameter, allowing me to do all of this.
Yeah.
It allows me to put a stent in with balloon, but it doesn't allow me to put 2 stents together. That's the only thing I cannot do.
Because you start with 5 French.
I'm sorry?
You start with the 5 French, as I said.
No, the 5 French were for diagnostic right. But for the left, I used an EBU 6 French guide.
Oh, okay.
The only other point to make really is that you spoke about whether your strategy would have changed after TCT last year. But I think what's important is that really you need to do something you're comfortable with in this situation rather than taking on a new technique just because there's a study. Do what you're comfortable with. This patient can potentially become unstable.
I think it's absolutely right. I think you should choose, again, anatomy dependent, depending on the anatomy, I think you should choose the technique.
Can I just add a comment? And this is a very interesting point that also you raised it during your presentation. I think that this trial are comparing routine strategy of DK crush versus one single strap provisional stenting. Now, I think that you cannot apply, I mean, the limitation is that it is a uniform strategy for all patients coming. Now you have the anatomy in front of you and you can decide what is the best for your patient. So I would advise against perhaps using these routine strategies, no use at all. This is the same issue also for thrombus aspiration. The guidelines say routine thrombus aspiration. If you think that is useful in that case, of course you can use it. And this is also for the DK crush technique. Should not be used as default strategy for everything.
I totally agree with the chairwoman. I think in midnight sitting there, it's not the time to do your first or second procedure on a left main STEMI patient like a DK crush. Do whatever you are feeling comfortable with and proceed with it. I mean, that's the way I see it.
I think DK crush trials patients all are chronically stable already.
Yes, they are not STEMIs.
That's my comment. First, I want to thank you about the case. This is an excellent case. I'm Dr. Othman from Ain Shams University, Cairo, Egypt. Actually, we have a running trial study about what they have been discussing right now, whether to do direct PCI for patients with the STEMI with thrombus burden, or to defer these patients and start with thrombectomy and giving intracoronary glycoprotein 2B3A. And the primary results for this trial currently is that the group that had been managed with primary PCI do better, especially if there is a lesion with the thrombus. And only if there is a thrombus only with no accompanying lesion, the group that have been deferred for later on PCI, if needed, do better.
So the non-atherosclerotic lesions might be your best bet on that.
Yes.
Okay, I think there are no further questions. I think we will close this session. And thank you for coming to this session. I think it's very important to emphasize that use of imaging. I think it's very important to make sure we use imaging in most of these left main cases.